Surgeons, let's watch this case that we operated recently. This is uveitic cataract with the dense posterior synechic at 360 and dense pupillary membrane. So starting with the two paracenteses and vision blue to stain the central anterior capsule because the peripheral one is hidden under the pupil. Now with the BSS cannula, we're trying mechanically to release the pupil and do some synechilysis. And then like staining again under the pupil. Like we're gonna use the vision blue dye to go slightly under the iris, but very gently. Don't inject too much, don't be very generous, otherwise the vision blue will seep to the burger space and will cause trouble like positive pressure and blue reflex. Now after that is done, main wound is coming in after filling the AC with viscoelastic. Now we are trying slightly to remove that pupillary membrane, but obviously it's not working, so we abandon that. Filling up the AC with more viscoelastic, and now we are introducing the pupil expansion device. First you have to unroll it and let it go and unroll inside the AC over the iris, and then we're slowly we're gonna introduce those anchors. They're gonna go in the iris and get tucked within the track that is designed specifically for the iris to go in within this device. It's like a tram track like. After that is completed, like all anchors were placed on the iris or the pupil, the capsular access is being done, gentle hydrodissection, and we are making sure that the nucleus is released now and the cortex is released. This is a young patient, and uveitic cataracts in young patients usually are not that dense, so we're gonna expect it to be removed very quickly. The surgeon is using the flip and chop technique. Now that is done, time some bimanual cortex removal. That is done very efficiently. You're gonna face these cases from time to time with the tiny pupils, so some people use iris hooks, some people use this device, some others use viscomydriasis, but when you are resident under training, it is preferable that you learn all these techniques and use them whenever needed. Now after the cortex is removed, we're going to dilate the main wound, and we're going to introduce the IOL. Some polishing is being done right now, both for the anterior and the posterior capsule, filling up the AC with viscoelastic, dilating the main wound with keratome, injecting the IOL after stabilizing the globe with the chopper. Now it is time to remove the ring. You're gonna unhook it from the iris or the pupil, and then slightly introducing the injector that it went in with. And here be careful, don't hook it from the anchors where the masked emojis are, because that area is very bulky and it will not be hooked to that injector. Rather hook it from the sides, not the anchors, but rather from the sides where the smiling emoji is. So now we rotated it to face that tiny track where the smiling emoji is. You're gonna hook it, and then it will extract all the way in. It's very elastic, and it folds and unfolds very quickly. So after that is removed, we're gonna remove the viscoelastic and form the AC. Thank you so much for watching.